one way to frame it, because sometimes with patients or with people, they don't always act professional and polite. They might be under stress, they might be screaming, they might be yelling, they might be justifiably upset about whatever's just happened. And so a big part of trauma-informed care is shifting that lens from what's wrong with you to what's happened to you.
So I'm Jean-Paul Michael. I am a community case manager that works in an inner city hospital in Toronto.
My name is Wiplove Lamba. I'm a psychiatrist, and I mainly work with people who use drugs.
Cool. So what are we talking about today, Wip?
So today's another core content talk. It's on trauma-informed care. And I'm just going to talk about a few different things. I'm going to talk about how I learned about trauma patients and how to work with them, how those philosophies and beliefs evolved over time, and where I am now. I'm not going to go into the PTSD diagnosis, post-traumatic stress disorder. I'm not going to go into post-traumatic stress disorder treatment. I'm not going to talk about PTSD treatment in people who use drugs, but I think that would be a phenomenal deep dive later on as well.
Okay, yeah. So I'm really glad this is the topic. This is something I struggle with all the time. When in all the various settings that I work in, you want to find out how people are doing, but sometimes you stumble into something really deep, right? And where they're disclosing something that's just so fundamental to where they're to who they are, right? And what their journey has been. But I feel like I'm kind of ill-equipped to handle some of the answers. You know what I mean? Like I feel like I don't want to kind of admit how kind of maybe poor my skill sets are, but I think they're really poor in this area, to be honest with you, because it's like somebody's talking about we go from how are you to, well, this is the 20th anniversary of when the person that molested me was arrested, right, or something like that, right? And I'm like, wow,
it's a lot.
It's a lot, right? It's just
a lot.
It's a lot, and I feel like that's how we got to from how are you to that, right? And then
and sometimes it happens really quick.
Yeah,
it happens really quick, and then you're not sure how to handle it.
Right. Any tips?
Yeah, I think there's a lot of potential tips for that. I also think it's a little bit different than the whole trauma-informed care and PTSD treatment. I think that comes under more the art of the interaction, right? And I think for me, the journey also started with similar experiences. So every topic that I've dived deep on, it always starts with a feeling of complete helplessness when I'm trying to provide clinical care in that situation. And sometimes I'm lucky, I can refer people to somewhere else, and then they get that care, and then that desire doesn't continue in terms of how do I get better at this, because I can just screen and connect.
So I'm not the only one that feels helpless.
No, we all do. And I think I'm convinced that the people that attend a lot of continuing professional development ones have those experiences that are motivating them. At least for me, that's what it always was. It was always a patient that I just felt helplessness with, not sure how to help. Then I'd start asking colleagues. I mean, and if it was a one-time thing, it's tricky. But if it's a one patient that I'm seeing regularly, or if it's like similar stories that are coming again, that's where I just have to learn and get better at it.
Okay.
Yeah, I think with that interaction that you had, it does get tricky because there's so many things that can lead to someone disclosing those kinds of things.
Yes.
Right. And sometimes it's because it's something that's on their mind, and that's the way that they deal with it. Sometimes I think it's the way that sometimes people know how to ask for help. I mean, if they know my suffering, maybe they'll see that I'm just not making this up, and that they'll help me in some kind of way. It's also something that leaves certain therapists feeling helpless, right? It's like when somebody talks about suicide and death, all of a sudden, how do you have a therapeutic encounter for it? I do think it'd be great to have a session where we can go over what are some things patients sometimes say that we don't know how to respond to.
Yep.
And then brainstorm around different answers and solutions.
Right. And so, I mean, as we both work in the field of addiction, I'm sure this comes up in every area of care, right? So
Yeah.
this is not exclusive to addictions, but then there's kind of that connection part of how do these traumas impact why they're using substances, right? And is that a major part? And even if it is or it isn't, is there anything we can do about it, right? I guess is the other kind of side of it. Like, do we explore that connection, or is that a connection worth exploring?
It absolutely is a connection worth exploring, and there's certain treatments that are really designed for that. And I think what allowed me to start to feel more comfortable with trauma is when I saw what the whole pathway can be for treatment.
Okay.
Right? So what that means is like, how do you do the assessment? What are the different diagnoses and comorbid conditions people have? What are the specific treatments for those conditions? Do you do them at the same time? Do you do them sequentially? Do you do them in different locations? And what are all the different treatments for PTSD? And once I had a framework for what that was, because I knew the long-term journey, I could sort of tell where things were going. It's just like, right now when you see somebody in hospital and they're in opiate or alcohol withdrawal, right? And they might be screaming about housing or something else. In your mind, you know that once you get that withdrawal more comfortable, you know what community services are available for housing. You know how long it takes to get into those programs. You know what situations would allow them to, like, once you know what that treatment journey looks like, it's a lot easier to handle that moment-to-moment crisis. At least for me, that's what happened.
Okay, so what you're saying, if I'm understanding you correctly, you're saying that that sometimes these issues are coming up because maybe we're not treating the addiction treating the addiction properly might lessen the experience of that trauma for that individual.
No, what I'm saying is that the uncertainty that we feel in holding whatever someone's discomfort sometimes comes with not knowing what we can offer for that.
Okay.
Right? Because think about it, you have someone that tells you this is the 20-year anniversary of the person who abused me going to jail. In your mind, you think about how many other anniversaries this person has. What are all these other events that affect them? How are they coping on a minute-to-minute basis with these things in their mind? And right now, I've got to do an assessment, and I don't even know how to help this person. This person's already been to all these programs.
Yeah.
And so it just perpetuates sort of this helplessness kind of thing. And I think there's a difference in terms of figuring out what to say in the moment so that you can do your job in a compassionate, caring way. And that's what more that trauma-informed care is, right? Trauma-informed care is whatever clinical care you have to provide. How do you do that in a way that's trauma-informed? It's knowing that this person's been through trauma. They may have reactions that are different than other people that come through. And how can I still do whatever I need to do in the here and now?
Right.
Whereas the part that helped me a lot with trauma-informed care is knowing what trauma treatment is, what different people believe around what the treatment pathways for that are, and that allowed it there. So trauma-informed is more about how do I work with the person knowing they've been through trauma, because when you're seeing them, you're not at a trauma treatment center.
Right.
You're not like doing a full trauma assessment and trauma treatment that you're offering them. You're not readying them for a journey for trauma treatment. You have a very different goal in that moment.
Right. So all right. So the definition of trauma-informed care, probably a good thing to start with, is, well, it may sound obvious but what is it?
Oh, I'm not even sure. People define it differently all the time. You think I'd have a definition for this, but
maybe it would be helpful.
But I don't.
But
I
think you just defined it though. Is what I'm saying is that you saying so it's not trauma-informed care. I mean, maybe it seems obvious, but it's keeping that in your mind so that you're navigating a conversation with any individual in front of you, so that you can don't trigger these things in a sense, in a way, right? So you're being
mindful enough to try not to trigger it, but almost anything can be triggering, right? And so this is where it gets tricky, right? So I think it's like one way to frame it, because sometimes with patients or with people, they don't always act professional and polite. You know, they might be under stress, they might be screaming, they might be yelling, they might be justifiably upset about whatever's just happened. And so a big part of trauma-informed care is shifting that lens from what's wrong with you to what's happened to you. Like, what's happened to you that's making you respond like that. And I believe that once we start thinking about what's happened to you...
I think that's important. So what's wrong with you versus what's happened to you, right?
Yeah.
I like that. Okay.
Yeah.
So that's part of that trauma-informed lens.
Yeah. And once you start to look at somebody as terms of what's happened to you to make you be this way, it doesn't mean you have to ask about all those things. It doesn't mean you have to get them to talk about all those things. That's their choice. But what allows you to do is have some compassion for why this person is becoming so angry and upset. Why, even though you did what you were trained to do in terms of, hi, how are you? We're going to go through our interview now. You close the door. All of a sudden, they're upset.
Yeah.
Right? It just shifts that framework. So as opposed to just immediately being like, relax, like, come on, it's more just like you create that safe place, and then you help them figure out how to relax so they can go through that assessment.
I like that. It's sort of like there's a little thing that I kind of put in my head when somebody reacts is various code whites and situations that I've been in. And sometimes I frame it, I don't know if this is trauma informed or not, but maybe they're doing the best that they can.
Yeah. Yeah, absolutely. Absolutely.
And if you look at it that way, then you could somehow trick yourself to not trick yourself, but accept that that's what it is. Then you look at the situation a little differently. Just as a clinician, I try to think of it that way, right? And that's and that kind of takes the blame off of it. And it's like
Yeah, and I think that's almost like a very reasonable sort of starting point. I think that's a great starting point. Because once you come from a lens like that, you almost turn down whatever natural responses you'd have, right? Because in real life, when you're not at work, if somebody starts swearing at you, someone starts yelling at you, someone starts to do something unfair, someone feels like they're being manipulative, in your personal life, you'd get upset as well.
Absolutely.
Right? Yeah. And if you come from a place of compassion, then it can shift a little bit too.
Yeah.
It's almost like a callback to, we were chatting a little bit earlier about call centers and phone calls and stuff like that. And I was saying, one day I was getting upset. Why do they keep calling? My phone just keeps ringing, all that stuff. And my dad was like, well, everyone needs to make a living, right? Everyone needs to make a living. Everyone needs to support and care for their family. And even just that lens allows me to be a little bit kinder, allows me not to take it so personally, and sort of end that piece as well.
Yeah, because regardless of the profession that people choose, they're still coming to work. They still probably got a wife and kids at home, and they're still being supported by their work.
Yeah, or whichever home situation they have, right?
Like but they're just like us.
Yeah, that's exactly
what
true.
I meant.
That's exactly true.
Yeah.
So for me, the interest in trauma-informed care and getting better at it is exactly the same way that you had, where it was like, I'm just not good at this. I just don't have this. And you get trained in a psychiatry residency to do a psychiatric assessment. And early on, there was a few mentors who were very good at what they do, where they really wanted to get a good trauma history. And when you do a one-time assessment, you get a great note, you give very, very good treatment recommendations. But what happened would be, when I would see these patients again, a week later, they would just tell me how difficult that assessment was. That was such a hard assessment. It was so difficult to go through. I had nightmares all week. All the stuff came back. I was having panic attacks again. And as a psychiatrist or therapist or whatever it is, it's very hard to hear that your assessment brought all these things out. And the more that I went through that, I started to think about some of these patients that don't come to appointments, and eventually, you work for a while, you start to hear like, oh, I couldn't come to the first visit. I couldn't sleep for the 4 nights before that assessment. I was so nervous about it. And for our patients who use drugs, what do you do when you're uncomfortable? You use substances, right? And so it's almost like that intense hour and a half assessment almost makes it impossible for some people to attend.
Mm-hmm. Yeah. I go in often after those assessments are made in hospital care. And
you have to help de-escalate?
Yeah.
Oh, there you go. No wonder.
Because there's it's almost like a resistance to speak sometimes. It's like, I'm not...
With you or with the therapist?
With me, because it's like, I'm not going through this again. I've done this once.
Yeah.
I'm like, whoa. I just, want to see how you're doing. And I'm not, I'm not going to go... I'm not casting aspersions on on the merits of doing that or not doing it, but in the aftermath of it. And sometimes it's tough in hospital care because you kind of got to, some people are in their bed and they feel obligated to speak.
Yeah, absolutely. Yeah.
You've got kind of a captive audience, bad expression, but kind of the true one, right?
Yeah. So I think maybe just coming back to some stuff you're asking earlier, when I have patients that I'm working with, I try to make it clear from the beginning, it's up to you what you want to share. Any question I ask, you actually don't have to answer. You can say, no, I don't want to talk about it. I don't feel comfortable talking about it, or any of those things. And then the other thing to remember is that whatever you do share and talk about, after this assessment, I'm not going to be around anymore. So you're going to have to sit with that, right? And so that's something we can talk about here. We can talk about different strategies. I just need that you're in the driver's seat. And so by setting a frame where they're in the driver's seat, they get to choose what they share, what they don't share. It sometimes allows for it, but it's tricky to say that because sometimes you have to ask about safety. You have to ask about other things as well, right? And in your situation, when you come in after the assessment, I see it more as a de-escalation kind of thing. How do you help them feel a bit more comfortable? And there's certain things that people recommend. They talk about grounding, right? So grounding, some people do 4, 3, 2, 1. I think, was it 4 things you see, 3 things you, smell, 2 things you feel. I always forget these things. But I think there's all these different grounding strategies that you can walk people through. You can demonstrate it during the session. And it's all about getting outside of your body and connected to the world around you.
This is your advice to the patient after they've been perhaps escalated from the assessment? Is that what you're
saying? Well, I'm saying for you.
Oh, for me.
When you come in, you come in blind. You don't know what's going on, and the person's dissociating right in front of you.
Yeah.
You can be like, what do you see around you?
Yeah.
What color are the walls? What color are the lights? And sometimes when that's it, they'll just sort of follow you.
Yeah.
And then you can just guide them, just getting outside of their body, right? Sometimes you can do it by moving, like physical activity, so...
Yeah, I think that, just back to your point about, what people are asked and you say you'll never see me again. And that kind of goes to like, well, then why am I doing this in some cases, right? Like, I'm never going to see you again. It's sort of like back to our, kind of our rapid access clinic model, right? Where they have to, they'll meet a peer. They'll meet a peer, they'll meet a caseworker, they'll meet a nurse, they'll meet a resident, and then they meet the doctor. And I think we all have to be mindful that we're not asking the same questions 5 times.
Yeah, but I think that's a leadership and a clinic issue, because what ends up happening with each clinician, you have a certain scope, certain things you have to cover,
right,
and you're always going to cover those, right? And so this involves some kind of leadership structure where either there's some kind of combined assessment, there's some kind of debriefing time, some kind of a connection for it, right? And so, because as an individual clinician, you're responsible to whatever body you report to, and so
I'm just speaking more from the trauma-informed lens of how do we navigate for this individual, so he doesn't have to say this story 5 times.
Yeah, and the only reason I'm sharing this, JP, is because that problem that you described is in every single clinic. It's in the emergency department. It's when someone comes admitted, the nurse asks, the front desk asks, all those things ask. And sometimes we help coach people where it's more about the headlines than the details and things like that.
Yeah.
Yeah,
so you're right. There's a division of labor and responsibilities and stuff, but I think to work as a cohesive team in any setting, I think maybe that is what trauma informed is, right? And that's maybe what why we're talking about it, right? It's how we navigate that, so we they don't have to relive their trauma 5 times. Perhaps not at all. Is it really relevant? Their past trauma to get a methadone script? No, not really, right? Like, that's not a requirement.
Is everyone asking about that? But it seems like it comes up.
It seems like it comes up because I think our folks are so used to having to justify themselves, right?
Okay. Yeah. So, remember when you said about how you meet somebody and they just start sharing everything?
Yeah.
So in that moment, this is a theory. This might not be true. I didn't read this in a book. But in that moment, who has the power? It's the peer. It's the counselor. It's the therapist. It's all that kind of stuff.
Yeah.
And in that situation where we have the prescription pad, we're trained not to give inappropriate drugs, whatever that means, right? The language, whatever. So it could be, you don't give benzodiazepines, you don't give stimulants, you don't give this, you don't give that, you don't give too much opiates, you don't go too fast on the methadone, whatever that might be. When someone shares their trauma, they're naturally trying to elicit that compassion. They're trying to elicit that trauma-informed care. And they're also trying to create a space where they have some control and some power.
Yeah. And I think it's like they feel like there's this, I need this script because, right? So it's like they're in the, no, you don't need to explain why you need the script, right?
Yeah.
You don't need to tell me what you've gone through to justify why you want to go from 40 milligrams to 50 milligrams.
Yeah.
First off, I'm not the prescriber. You don't need to even tell me this part, right? Although sometimes it's helpful, as in our kind of division of labor, that the prescriber has a little bit of a heads up as to what the patient needs.
Yeah.
And if we work as a well-oiled team, and we often very much do that, then they say, oh, so then when they meet with the prescriber, it's like, oh, okay, I see you want to do this. That sounds reasonable. Absolutely. Done. Right. So the time at the top of the pyramid is the shortest time, because that's the way we try to structure it when it works well.
Yeah.
But there always is this feeling that the patient seems to need to justify themselves, and and that's wrong.
Yeah, and so in the interview process, we talked a bit before about what you ask versus how you ask it and so forth. And one thing I always try to do is I always try to give it a little bit of space in the beginning for people to talk. I validate the stuff that they've said. If the trauma stuff comes up, I'll validate that you've been through a lot, Sharon. And then I also try to make it very clear that it's their choice what they share and how. And then there comes a point where, and everyone develops their own line for this, you've been through a lot, you're going through a lot of things. And in order for me to do what I need to do so we can get you the help you need, you came here for meds, or you came here for this, there's certain questions I need to ask. And if you give that framework in the beginning that they can speak, they're so open to you interrupting them later, right? So you can get that information in. But if you don't let them speak, it just ends up taking sort of a forever. So I think for the examples you're describing, where someone comes in talking about trauma, just that lens that allows you to have that compassion, like whether it's what have they been through that's making them go through this, or they're doing the best they can, whatever that might be, giving them a space to speak, letting them know it's their choice, whatever they share or whatever they don't share. For that trauma piece, you can let them know that as well. You can be explicit. For the trauma, it's your choice what you share, what you don't share, all that kind of stuff. And I think that's sort of a good way to frame it.
Okay, I like that. So you've been through a lot.
Yeah.
To answer my first question. That's one of the tips, right? So that's something you can say.
It could be a tip, yeah. And what I find I like the most, I don't always like reading books or textbooks or things. I love asking people, what do you say to the person? How do you work with them? And you talk to 10, 15 different therapists or caseworkers or peer support workers. They figured out a formula that works.
Right.
Because the numbers are so high, right? And if something doesn't work, they're not going to use it again. And so when people give a talk, I don't always... I just want to know what they say. What are the words that come out of your mouth when you're working with someone? Because I would love to have that level of effectiveness.
Okay, that's good.
So there's a difference between creating a space than actually doing the trauma history. And I wasn't going through that today, but I'll just share because you've asked. So superficial to start with them in the driver's seat. Sometimes I'll do a screening tool, like a primary care PTSD screen. It's like 5 questions. I'll put it in the link. The 5 questions are very simple. Sometimes people have gone through things in their life that are incredibly frightening, horrible, upsetting, or traumatic. It could be being in an accident or a fire. It could be having a loved one die from homicide or suicide. It could be a past history where you've been physically or sexually assaulted or abused. It could be something where you've been in a natural disaster, earthquake, or flood. Then I'll say, have you been through an event like that? If they say yes, then I'll say, in the last month, have you had nightmares or flashbacks about the event or thought about it when you did not want to? The second question I'll ask is, do you try hard not to think about it or avoid situations that remind you of it? Then I'll ask is, do you feel numb, detached from people, activities, or your surroundings? Fourth one would be, do you feel on guard, watchful, or easily startled? And the last one is, do you feel angry at yourself or guilty yourself or others for the event or the problems the event may have caused? And if they say yes, and then they have about 3 of the 5 ready, then I know there's a strong signal they might have current symptoms of post-traumatic stress disorder, and it sort of guides things that way. And I did that a lot when I worked in a place that had a direct pathway to trauma treatment, but I found those 5 questions were very contained, and I sometimes preface it before. There was a psychiatrist I worked with who's now in North Bay, Dr. Whitney, she's phenomenal in terms of how she does things. She worked on the women's unit at ChemH for I don't know if it was like a decade or two. And what she asks is for the traumatic events, she'll ask, what it was, but she'll mainly ask what were the ages that it happened during, who was the perpetrator, how did your friends or family respond when you told them about it? And then the most important question she asks is, how's it stayed with you in the here and now? And I love that question because it helps me know, what do I need to figure out now? Is this somebody having nightmares? Are they having flashbacks? Are they not able to leave their house? Or is it something more nuanced, like it's hard for me to trust people, or I trust too much, and I get hurt? And that's what I do around the trauma assessment. But I see it very different than what trauma-informed care is. And for me, it all started with feeling completely helpless with patients I was serving after I was out in practice, because I knew how to do a psychiatric assessment. I knew how to give treatment recommendations for it. I knew various forms of basic therapy and counseling. But for a lot of our people we see who use drugs, they're not in a state where they can do the full PTSD treatment, and even just regular interactions with people in power, people of authority, is very, very difficult for them.
Okay. Is trauma and PTSD the same thing?
Yeah, so it's not. It's not. I mean, it's linked. So PTSD stands for post-traumatic stress disorder, or it could even be an after-trauma stress reaction that stays with you. And I'm not sure what the exact numbers are, but I think only about a third of people who are exposed to these dangerous events end up having symptoms of PTSD. So not everyone who goes to war and kills someone or sees someone who dies beside them has those symptoms when they come back. Not everyone who's been physically or sexually abused has those traumatic symptoms when they come back.
Is trauma a precursor to PTSD?
Trauma, I mean, I would define trauma as what the event is.
Anyone with PTSD has probably experienced some trauma?
Yes, you have to have.
Okay, that's
right.
So that's why I said it's sort of a precursor, no? So you had to have had
prerequisite. Yeah,
to get there.
Yeah.
Okay.
So for trauma care and treatment, it was something where I think I was out in practice for a couple of years. I'd done my psychiatry residency. I was mainly working in an addiction clinic. And I had a patient where I was just, I already had those situations where people had come back and told me about how upsetting the interview was. I got a bit more comfortable with how to frame the interview in a way where some of the emotions could be contained. And then a couple of situations happened within the course of a week where a patient of mine was just sort of teaching me about grounding. And I felt completely, how come I had not heard of this grounding thing? And then a colleague of mine, who's a social worker at a family health team, shared a book that she found very inspiring. It was by Bessel van der Kolk. The book was called The Body That Keeps the Score. And Dr. van der Kolk is a psychiatrist in Boston who's done a lot of work in trauma. And I went through the audiobook as well. I got it from the library back then. I had a CD player in the Honda Accord that I was driving. I love driving that. It was the first car I ever got, right? And really enjoyed. Anyway, so I had it in the car, and it had like 4 or 5 CDs, and I just went through it on the way to work. And the book was fantastic, but it was also so upsetting to go through. I'd done a 5-year psych residency. I'd written my Canadian psychiatry exams. I think, I hadn't written the US ones yet, but it had all these evidence-based treatments I'd never heard of. And I'm like, is this just a gap in my curiosity? Was I just not paying attention? What happened here? And it ends up being, and the same thing happens with substance use care. That's why a lot of our talks are on topics that people don't always talk about in addiction. When you go through PubMed and the literature, there's all these evidence-based treatments that have not spread.
Right.
And right now we're in this CBT world of cognitive, changing your thoughts to change how you feel, to change how you act. And when you think about some of the people we see that are so dysregulated, it's very hard to change your thoughts.
Yeah.
If they could follow a structure of rules and things, they wouldn't be in this situation right now. And so the whole thing, it had stuff like mind-body work in there. It had internal systems therapy. Every chapter was a different therapy that could help people. and it just it's like, you know, when you think you're good at something or you think you're good enough and you just see all the flaws in how you are.
Yeah.
So the book was phenomenal, and in that book he talked about when the DSM-5 was being made, they were pushing for a disorder called developmental trauma disorder. So PTSD is very circumscribed. You have to have an incident event, or now you could have vicarious trauma. So say if you're a first responder and you have those symptoms repeatedly, you could have it.
Yeah.
But then you have to have a certain number of specific symptoms around, like either remembering, nightmares, flashbacks, cognitive changes, physiological responses, and it's cause a deficit in your life, right? So you have to meet all this sort of criteria for it. And he was saying that, what do you do for people that have multiple traumas? How do you approach people with multiple traumas? And we call that more, I think, complex PTSD now. That's in the ICD-10. But back then in the DSM-5, he couldn't get it in. And I read his paper. It was like 40, 50 pages. It had like 100 references for it. And there was this International Trauma Society. I think there's a couple of them. But this one really believed in the diagnosis. And he couldn't get in the DSM-5. And he was just sort of saying how their response was that there's no evidence for it. And it was just a bit sort of upsetting, you know, in some kind of way that you could have someone that has this thing and doesn't sort of get to that point.
Right.
And he talked about how people with trauma respond differently to situations. So imagine I'm at home or whatever, you're at home and you smell something burning. What are you going to do? You're going to panic. You're going to run downstairs. You're going to look everywhere. You're going to look at the stove, look at the fridge, look upstairs, look at the furnace, whatever that might be. And if you find a toaster where it's on and there's like a little flame and the toast is burning, you would unplug it, you'd somehow put that fire out, and the flames would sort of go away. And after about 10, 15 minutes, maybe you'd calm and relax in some kind of way, and you realize the house wasn't burning down. So what happens with people with trauma? They'll do the exact same thing that you did, but they don't calm down after 10, 15 minutes. They have an hour or two where their body's responding like the house is burning down. And so for people with trauma, what happens is that they always have their spidey senses on. They're always sort of like on guard, waiting for the next thing to happen. The responses are sort of really, really intense, and they're not really able to label what's happening in terms of the emotions or the experience or what's going on. And then the other thing is, when these situations happen, they don't learn from that experience. So they don't learn that the fire was on, I took the fire off, now the risk is gone. Just the fear just sort of stays constant. And sometimes there's this over preparation around making sure nothing could ever burn down or whatever it might be. And so, yeah, no, I think that's what happens for people that have the PTSD experience. The other thing I wanted to quickly talk about was
sometimes burnt toast is just burnt toast, but for other people, it's a lot more.
Yeah. And they can't change, like, even though logically they might be able to see that the fire stopped, their body's still responding. Their body's still responding like it's chaos. It absolutely is.
Okay.
The other things I was going to bring up were the ACEs score.
Okay.
So like the adverse childhood experiences. There's been a few studies in the States where they found out that 5 or 10% of certain patients that they see take up about 80% of the healthcare costs.
Okay.
And when they looked at these patients, these are the ones that had those adverse childhood experiences. So multiple moves, maybe some physical trauma, parents separating. I can't remember all those events, but we can put that in there. And so a lot of people now, when they're doing trauma assessments, they'll include the ACEs scores as well.
Okay.
In the hospital setting for trauma-informed care, it has all these things where they're really centered around compassion, like shifting that lens from what's wrong with you to what happened to you.
Yes.
But the thing for us is, I think we need to aim higher. I think we need to aim where people have a trauma-informed approach, and we figure out whether or not they have PTSD or complex PTSD or what psych diagnosis.